All right, welcome. Looks like we have 166 people today. That's fantastic. My name is Arjun Iyer. I am the Assistant Director of Multimedia Medical Education. Means I make podcasts and videos and try to do fun innovations that are basically the stuff besides text that we do. I'm also an emergency physician, working about half time. So I have with me today a Dr. Paras Vakaria and Brian Smith. Paras, would you like to introduce yourself?
Sure, thank you. Hey guys, my name is Paras. I'm a current dermatology resident here in Dallas, Texas. I'm also an RX coach with USMLE-Rx, so I work one-on-one with students to help prepare them for the USMLE Step 1 and Step 2 CK as well. And I'm happy to help out with tonight's session.
Awesome. What about you, Brian?
Hey, thanks, Arjun. My name is Brian Smith. I am a current ophthalmology resident in Philadelphia, Pennsylvania. And like Paras, I too am an RX coach with USMLE-Rx. So I work one-on-one with you to help you reach your goals on the USMLE and COMLEX exams. I'll be helping answer questions in the question box tonight, so feel free to ask away.
Yeah, so what we're going to be going over today is a lot of what you would get with RX Coach with two of our best and brightest. So without further ado, here's what we got on the docket. So today we're going to be covering the USMLE COVID-19 updates, talking a little bit about the RX bricks. Before the main event, our approach to questions. How do you tackle these multiple choice questions in the optimal test taking manner that makes the most of your valuable time on the test? We're going to go through a few different question dissections with our extremely talented Brian and Paras. We're going to wrap it up with some dissection tips and some study tips. And then we're going to close out with the raffle and the special offer before opening the floor up to questions. Glad to have you all with us tonight. And let's get started. So some COVID-19 updates. So for step one, the USMLE Step 1, as I'm sure all of you know, reported transitioning to pass-fail on January 26th, 2022. This probably then applies to all of you. The passing standard increased by 2 points as well, and the CBSEs and the CBSSA no longer report a 3-digit score at all. They're simply going to report pass-fail. The implications of that are way too broad to go into for this webinar, but they are going to report an overall percentage correct, as well as an estimated probability of passing step 1. COMLEX as well is going to go pass-fail, but that's only going to take effect May 1st, 2022. But a little bit more about question types. So, on step 1, if you've done any questions or heard anything about the format, the name of the game is one best answer. So while in real clinical life there may be many possible answers, there's only going to be one correct answer that is the best of all of them. There's going to be a few with multimedia like X-ray interpretation, hard auscultation, long auscultation, etc. But the vast majority of them are going to revolve around the clinical vignettes, which are 80+% of the exam. Do I have that right? Is that in reference to clinical vignettes? I feel like it's even more than that. Maybe I'm out of the loop. They also are going to incorporate multi-step reasoning, so very little direct recall, much more know what's going on and then answer something about that. So step 1, step 2, and step 3 focus primarily on different things depending on your stage of education. Step 1 involves the mechanisms of disease. Step 2 more involves diagnosis. And finally, step 3, which generally people take after medical school, is more focused towards management. And here you can see kind of a rough breakdown of the various competencies that are tested on step 1. As you can see, it's fairly heavily weighted towards medical knowledge, but there is a significant amount of patient diagnosis there. That percentage will, of course, increase for step 2. Management of note is none of the test. And correct me if I'm wrong, Paras and Brian, but this has really been a recent push to shift the management type questions to step 2, and even more than that, step 3. Is that correct?
I think that would be my understanding as well.
Gotcha.
Yeah.
Yeah. In addition, there's communication and interpersonal skills and practice-based learning and improvement that make up substantial minorities of the test as well. But the one kind of important takeaway from this is the fact that, older, I guess, practice materials may have you do some basic management stuff. They really kind of gutted that from step 1. Quick plug for the bricks. If you don't know about the bricks already, they are an awesome online resource, a multimedia enriched platform for primary learning for all primarily preclinical topics that you could want to learn about. You can go to www.usmle-rx.com and get a wonderful, interactive, accessible primer to any of these preclinical topics that you're going to need to know for step 1. And they're done in a modular format as well. So can't say enough nice things about the bricks. On to the main event, our approach to questions. So there's different approaches to board questions, but our superstars in the RX coach program have refined a methodology that's worked really, really well for the students that they teach. For those of you who haven't heard of RX Coach, I mean, it's the tutoring initiative that both Brian and Paras are a part of. And what I want to do actually, rather than in keeping with adult learning theory, let's do some learning by doing, rather than talk in abstract terms. So let's go straight to question number 1. And Paras, I'm going to tap you for this one. So
yeah, absolutely.
Says, a 68-year-old, well, actually, how would you read this question, Paras? I was just going to read it from the start.
Yeah, that's great. So, one of the first things we actually recommend in our first step actually is to cover up the answer choices. And you can see that we've actually done that here. So if you're at home and you're going through questions, using a piece of paper or Post-it note to cover up those answer choices. We don't want you to become preoccupied by them. We don't want that to guide your thinking. So that's actually our first step.
We did that work.
Go ahead.
I said we did that work for you.
Yep, absolutely. Yep. And then kind of to answer your question, Arjun, the second step, actually, we actually recommend reading the last sentence first. So I know you mentioned that you were maybe planning on starting the question at the very beginning, but we actually recommend reading that last sentence, the actual question part. We do this so that, we know what to look for, and then it'll give us a sense of what we need to pick up on in the actual vignette of the question.
Okay. All right. So the last sentence, which of the following is the most likely explanation for the patient's findings? All right. So that tells me that I'm going to be looking for basically what is going on. What is this clinical picture telling me?
Exactly. Yep. And one of the other things, and kind of actually the next step 3, is in interpreting that last sentence to figure out how many steps you think that question might be. Questions can be 1 step, 2 step, or 3 step. An example of a 1-step question would be if you just needed to find the diagnosis. An example of a 2-step would be if you needed to find the diagnosis and then know the treatment for that diagnosis. A 3rd step would be if they took it a step further and then asked about like the mechanism of action of that drug. Okay. So you are so one of the next steps you should do when after reading that lead-in statement is try to determine how many steps you think this question is.
Well, gosh, I mean, it could be one. It sounds like read the paragraph, figure out what's going on. Is that right, Paris?
Yeah, that's a great way of looking at it. I think one of the things we try to work on with students is, really breaking things down into separate concrete ideas. So, I think one way of looking at it is let's come up with a diagnosis, the what's going on with this patient. And then two, when they ask about explanation, maybe they're asking about pathophysiology, or maybe they're asking about the mechanism for why that's happening in the condition. So there could actually be another step there, and if we break it down into those concrete steps, this might actually be more of a two-step question.
Pretty sneaky, Paris. All right. Oh, nothing. I'm just providing color commentary. And what's the next step in tackling this question?
Great step. So now we would kind of recommend moving on to step 4, and that's actually reading the question, the vignette part of it, and reading through it one sentence at a time. And as you go through each sentence, kind of take a pause to incorporate that sentence into what you're thinking. What should you be getting out of each sentence as well? And so for today's purposes, we can kind of take a little bit of a brief pause after each sentence, so you guys at home can kind of gather your thoughts after each sentence.
All right. So a 68-year-old woman comes to the physician because of 3 months of worsening pedal edema and dyspnea on exertion. I'm going to give you guys 10 seconds to cogitate on that one. I mean, I don't know about you, Paris, but when I think of pedal edema and dyspnea on exertion, I think of heart failure. What do you think of?
Yeah, that's a great question. You definitely want to think of something that's causing fluid overload. And in this situation, where is the fluid overload? When you're talking about pedal edema in the legs versus maybe edema in the lungs, what is the difference between those kinds of edema that we'll talk about? But absolutely, that's a great pickup.
Okay. Next sentence. She has poorly controlled hypertension. Give you guys a few seconds on that one. Well, I mean, I'm glad you told me to kind of broaden my horizons from heart failure, because you're right, it could be a bunch of different kinds of fluid overload. And hypertension could actually predispose someone to both heart failure or kidney failure. So, yeah, either one. Her blood pressure is 150 over 96 millimeters mercury. All right, it's kind of going with the previous sentence. Physical examination reveals 2+ peripheral edema, bibasilar crackles, so kind of stuff we knew, and an S4 heart sound without murmurs. Ooh, think about that one. All right, so an S4 heart sound. If I think about that one, that's the one that goes a stiff heart, right? Not Kentucky.
Yeah, that's a great way. There are certain mnemonics that we can use to kind of differentiate those extra heart sounds. And it is fair game to be able to pick up on an audio version of the murmur as well. As they can definitely place the audio of a murmur and have you pick up on that. But it's also important to know not just what the sound is, but what does it mean if you have that heart sound, and we'll talk about that as well.
Echocardiography shows a left ventricular ejection fraction of 55% and marked concentric left ventricular hypertrophy. All right, think about that one for a moment. So, I mean, I'm going to be honest, Paris, in the emergency department, there's so much beeping and booping going on, and so many, psych patients from the core yelling about stuff, that I'm a little rusty on what my heart findings mean. But I mean, the echo findings show me that the ejection fraction looks pretty okay. The concentric hypertrophy, though, I mean, that kind of goes with a stiff heart, right? Diastolic failure?
Yeah, that's a great pickup. That's definitely a plausible explanation for what might be going on, especially when you take into account that those echo findings, like you mentioned. So I think that's a great thought there. Absolutely.
I'm feeling pretty good about this, Paris. So I'm glad I kind of read that step by step. What do I do next?
Yeah, that's a great question. So now, after you've read that vignette and you've gone through that sentence, one sentence at a time, now we actually recommend step 5, which is to reread that last sentence, the actual question component.
All right. So which of the following is the most likely explanation for this patient's findings? So, I mean, while I will admit, Paris, I did kind of jump to heart failure a little fast. Could be kidney failure and fluid overload. Who knows? But now, kind of with the other stuff, I mean, I kind of feel like I want to double down on heart failure, but now I can be a little bit more specific about it. Diastolic heart failure or HIF-PEF.
Yeah, absolutely, and that's part of the reason why we recommend reading that last sentence once before and once after. You can kind of get a little bit of new insight gained after reading that vignette. And so then we recommend moving on to step number 6, which is actually, the easiest step. That's when you uncover those answer choices.
Boy, that's going to take a little bit of self-control. Y'all ready for this, audience? Let's go. Answer choice A, aortic stenosis. Answer choice B, impaired left ventricular filling. Answer choice C, infiltration of the myocardium with protein fibrils. Answer choice D, obstruction of left ventricular outflow due to increased LV wall thickness. E, right ventricular failure due to parenchymal lung disease. Well, that's a lot of hard-sounding stuff. How do I go about tackling these? Just pick the one I think is right?
Yeah, that's a great question. And actually, this actually brings up our next step number 7. When we work with students, we actually recommend that as they're going through those answer choices, that they actually start at the bottom and work their way up to the top. So start with answer choice E, and then work your way up to answer choice A. Don't worry about, this question. We'll use that as a learning experience. So on our next question, we'll have you do that. But the reason we recommend that is because, a lot of times we see students who, will do that. They'll start at the top and then they'll see something they like, answer choice B, answer choice C, and they'll select it without having gone through all the answer choices. So that's why we recommend actually starting at the bottom and working your way up to the top.
All right. I see where you're going with this. And after every single answer choice, what do I do? Do I give it a yay or nay?
That's a great question. So you're ideally looking for an answer choice that really kind of fits with what you were thinking before you uncovered those answer choices.
Okay.
So that would be the ideal scenario.
All right. So I'm going to read answer choice E. It says right ventricular failure. I don't know about that. I mean, it says left ventricular concentric hypertrophy. I think it's an LV problem. I mean, there may be RV failure component of it because of the edema, but I think the main issue, one of the main issues is, fluid overload in the lungs. So I'm going to say no to E. Answer choice D, obstruction of LV outflow due to increased LV wall thickness. Well, that last part sounds pretty tempting, but I mean, and if I were reading really quickly, maybe that'd be a tempting answer. But the first part, obstruction of LV outflow, I mean, I feel like I'd hear a murmur or something with that. So I'm going to say no to that. Answer choice C, infiltration of the myocardium with protein fibrils. I mean, I guess that can lead to a patient having a stiff heart. And answer choice B, I see you, Jeff, but this is just the walkthrough. Starting with the second one, I'll poll the audience. How about? Does that work? I'm gonna assume it works. So infiltration with protein fibrils. I don't feel like I have enough information to say this is right. And with LV hypertrophy and poorly controlled hypertension, I mean, it sounds like is really just, you know, diastolic heart failure from cardiac hypertrophy. Impaired left ventricular filling. Wow, that sounds totally like diastolic failure. I like B. Can I stop here?
Yeah, that's a great question. Usually we recommend that, if you see something that matches with, completely matches with what you were thinking, it is okay to go ahead and select that. But, it is always to be thorough to just make sure that you're going through all the answer choices, and that the other one isn't maybe even a better, more focused or detailed explanation that fits with what you were thinking as well.
All right, fair enough. So answer choice A, aortic stenosis. Yeah, I mean, sure, I guess that could lead to LV hypertrophy and diastolic failure. I feel like I should hear a murmur. Paras, is it possible that they're tricking me and that, because I'm an emergency physician who doesn't use my stethoscope very often, that maybe I just didn't hear the murmur and that's my error?
That's a good question. No, usually you don't have to worry about these questions tricking you in that way. If they tell you something outright and explicitly, like there is no murmur, or you hear an S4 heart sound, you should take that at face value.
Okay, all right. So I feel pretty good about B.
Okay, great.
So let's see what we've got. And the answer choice is B, impaired left ventricular filling. Solid. All right, that sounds pretty good. All right, shall we? So yeah, Paras, do you have any other words of wisdom for this question specifically?
No, I think that was great. I think as we go through these questions, and Arjun, I know that we kind of went through those steps one by one, but now maybe we can start to piece those steps together. You picked up on a lot of important clues in that vignette. Most right off the bat was that fluid overload. But it's important to note, like we were mentioning, that it's fluid not just in the periphery, but also in the lungs as well. Okay, so you've got fluid overload due to heart failure, but both peripherally fluid overload and in the lungs. And we know that this patient, like you said, has poorly controlled hypertension. So that probably is the cause, and as we know, that is a cause for diastolic heart failure, like you said. Okay, so those are some great pickups on your part as we went through this question.
I felt pretty good about that. Thank you for guiding me through that, man. Looks like I shuffled the deck out of order, so let's go on to question 2. Paras, you think our students are ready to tackle this one on their own?
Yeah, I think so.
All right, audience, you get a crack at this one. Less of me talking. Question number 2. And I'll leave you, what's a reasonable amount of time? 2 minutes? Should I play the Jeopardy music? Do 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 do. Do 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 do. All right, and here are your answer choices. So students, we're going to open up a poll. Jeff, I think you've got control over that one. And why don't you go ahead and pick the best answer choice? %35% have responded, 40%, all right. Remember, this is a judgment-free zone. We're only going to judge if you abstain from voting. What's our critical mass there? All right. So Brian, oh, never mind. So it looks like we have bicuspid aortic valve and coarctation of the aorta as our top 2 choices. followed relatively closely by atrioventricular septal defect, and at a distance by narrowed coronaries and papillary muscle dysfunction. So, Brian, I'm going to give this one to you. Why don't you tell me how you would go through this question, start to finish?
All right. So, the first thing that I always do is I like to follow the RX method that, we kind of went through on the last session or last question. So the first thing I would do is read the question itself first. So which of the following cardiac abnormalities most likely cause this patient's symptoms? And after I read that, I'm trying to get an idea of what this question is asking. So I like to think, is this a one-step question, a two-step question, a three-step question, or more? And I'd encourage everyone in our audience tonight to write in the question box what you might think this question was. I know we've already guessed on the answer here, but I think that that's important to help develop a framework before we answer or start reading the vignette as to how to logically think through the vignette and work towards the answer choice. So next we'd go through the vignette sentence by sentence and think about what we might want to highlight after each sentence and what's important to us. So a 45-year-old woman comes to the clinic because of a 2-week history of substernal chest pain when climbing the stairs, relieved with rest. She has a history of infertility. Her pulse is 82 beats per minute. Blood pressure is 124/84. Physical examination reveals short stature and a webbed neck. A 3 out of 6 mid-systolic blowing murmur is heard at the right upper sternal border, and her pulse is delayed. So from that standpoint, you'd want to develop, a diagnosis that you might think of. So some things that I find interesting are, we have a 45-year-old woman. Her complaint is always important, so substernal chest pain. That's relieved with rest. The history of infertility, as well as some short stature features with a webbed neck. So that makes me think that our patient may have more of a congenital disorder, that there are physical examination findings for her stature, possibly something along the lines of Turner syndrome. There is a murmur, so I think it would be important to think about that and where that is located. And going from there, I would encourage us to go down to the answer choices. And like Paris said previously, we start from the bottom and actually work our way up. So the first is papillary muscle dysfunction. So think about if we want that. And then we go up, narrowed coronary arteries. C, coarctation of the aorta. B, bicuspid aortic valve. Or A, atrioventricular septal defect. And I'm actually going to defer to Paris to take the rest of this one because I did not prepare explanation for this question.
Well, I mean, if I'm looking at these, I mean, the one that Turner's is really associated with is a bicuspid aortic valve. If I'm looking to see, I mean, does this fit with the blowing systolic murmur? Yeah, I mean, bicuspid aortic valves, bicuspid aortic valves can certainly cause a degree of aortic stenosis. Could it be coarctation of the aorta? As far as I'm aware, that's not nearly as associated with Turner syndrome as bicuspid aortic valve is. AV septal defect is a congenital abnormality. So if you weren't sure it was Turner syndrome, then that might be tempting, but that is not one that is particularly associated with Turner's. And narrowed coronaries and pap muscle dysfunction, I mean, those are not typically congenital abnormalities. So I think if you pick up on the fact that it's probably something congenital, you could at least narrow it to 3, as is, my guess would be bicuspid aortic valve. And the answer is B, bicuspid aortic valve. Gosh, it helps to have the answers on the slide. All right. Any other words of wisdom for this question, either Paras or Brian?
No, you guys both did a great job of picking up on those very relevant clues in the vignette, and also knowing exactly what the lead-in was asking you. Like you guys said, this patient likely has Turner syndrome. There were a few clues that Brian picked up on: that webbed neck, the murmur at the right upper sternal border, the short stature. And in this condition, you have females who either have a damaged or missing X chromosome. And patients with Turner syndrome can present with aortic stenosis or even aortic coarctation. Okay, so it's common for these patients to have a bicuspid aortic valve, which is why this younger patient may be developing aortic stenosis. Usually, we think of that as a disease that we get later in life due to just chronic wear and tear and calcification. So the young age there would also maybe point towards a congenital abnormality causing that aortic stenosis. So great job, both of you guys, on this question.
I'm feeling pretty good about this this method, Paras, and I would like to know personally where to sign up for RX Coach so that I too can become as smart as you guys. All right. And finally, question number 3. And again, this time I'm going to put a minute on the clock. That's how much faith I have in you guys before I reveal the answer choices. All right. And here are your answer choices. And Jeff, you want to pull up that poll for them so that those who know can start voting?
Yeah, so the problem with the poll is that you don't get to see the graphic. So you may want to just take a good look here and make sure you've got a good sense of what you think should be going up, what you think should be going down in the situation. And because once we pull up the poll, you'll only have your letter option.
All right. 15 more seconds.
There you go. Okay, we're going to go ahead and launch that poll.
Let's do it.
Figure out which one, A, B, C, D, or E. Okay, we're going to go ahead and close that poll.
All right, so we have C as the most common answer choice, but we've got a pretty good spread here. That's followed very closely by both B and D. That's how you know it's a tough question. And at a small distance by A, and then finally E. So Paras, you want to walk us through this one? Tell us how you'd tackle it.
Yeah, absolutely. So, the first thing I saw was that, when I read that the lead-in question, it was asking about physiologic parameters. So I knew that they were maybe going to give obviously more than one parameter, and it might be one of those up-down arrow tables, and that's kind of what it ended up being. And then when I looked at this question, I kind of went through that vignette, and I went through it sentence by sentence. Some of the important takeaways for me are this was a 75-year-old resident, but not just a 75-year-old patient, but they specifically came right out of the gates and said this was a nursing home resident. So I thought that was important because we know that nursing home residents might be at risk of certain conditions more so than someone who's not in a nursing home. And then as we found out, this patient, was confused. and a few days ago developed a productive cough with green sputum. So I thought that was important history to what may be going on in the question. Then they gave us some important vital signs, and I thought those were all very important and a little bit abnormal. We have a patient who's febrile, tachycardic, and hypotensive. So we know there's a few things going on there, and those things kind of fit within the category of shock or sepsis, and we'll go in a little bit more into what that category is, but definitely abnormal. And then when we look at those lab tests, we also see that there are a few abnormalities, and our white blood cell count is elevated, so we've got a leukocytosis. We've also got a thrombocytopenia, platelets of 50,000, okay? And importantly, and very important for mortality as well, but the lactic acid of this patient is elevated as well. So we know that this patient maybe isn't doing that well. So from this, I kind of needed to figure out maybe what was going on in the patient, what was the diagnosis here, and I kind of came to a conclusion that maybe this patient was developing a type of shock as a secondary manifestation of that initial pneumonia a few days ago. Maybe that's why now they're hypotensive, tachycardic, and obviously febrile as well. So that was my working diagnosis, and then I needed to go down to those physiologic parameters and figure out which one of those fit what I was thinking. And I know that those are parameters that we see a lot in different types of shock. There's cardiogenic shock, neurogenic shock, hypovolemic shock, distributive shock. And so those values and whether they're elevated, normal, or low can really help clue you in as to what kind of shock this is.
Are you still with us?
Oh yeah. So that's I'm a little bit biased because I did help prepare the question, but I was leaning towards answer choice B because this does fit more with the distributive type shock. With the distributive type shock, you see a low systemic vascular resistance. So that was the first thing I was looking for, in that SVR, is it low or elevated? And I see there that there are only actually a few, 3 out of the 5 that have that. I know really that this patient is tachycardic, so I would imagine that cardiac output is going to be increased as well, okay? So I would expect that cardiac output would be high. I also know that this isn't cardiogenic shock, so I don't expect the pulmonary capillary wedge pressure to be abnormal. So that's kind of when I started to clue in on answer choice B. And then I know with distributive shock, your central venous pressure can be normal. It can be also slightly low, but it can also be normal. So that's kind of when I definitely was deciding to go with answer choice B.
Yeah, that's why we don't stick central lines in all our septic patients anymore, huh?
Absolutely.
Can you imagine? That's invasive as heck. All right, fantastic. And indeed, the answer choice is B. Awesome. Well, thank you for walking us through that, Paras. Shows you how the pros do it. So step 1, disease diagnosis. Recognize that the patient has septic shock. Step 2, figure out that the disease mechanism of septic shock, at least in the context of all these answer choices, is distributive shock, primarily defined by the low systemic vascular resistance. And step 3 is basically go through the other aspects of the answer choices to determine which one fits with distributive shock best. All right, I think I got this, man. So to wrap this up, a couple of question dissection strategies. Let's see if I got this right, Paras and Brian, see if I learned something today. 1, have an approach. I think I have one now. 2, when selecting an answer, utilize all of the information provided, not just some of it. Don't just randomly ignore things. Okay, they're telling, and I gotta double down on that one, because when they say something on in the question stem, they're telling it to you for a reason. They're not tricking you. They don't try to throw gratuitous red herrings. there's probably a reason. And 3, each question is created to test a set of related topics / content areas. Some study tips for you guys, because, you know, a lot of this is about getting this kind of spaced repetition that you need, and doing enough of these to feel comfortable with it and comfortable with your methodology. 1, establish a study schedule and stick with it. That's important. Don't pile so much on your plate you can't possibly handle it. 2, alternate study methods for variety. Don't assign yourself to, you know, sit down with the first aid book for 5 hours a day. Try to add some variety to that. It keeps you engaged. 3, save the crammable subjects for the end. They're crammable for a reason. Things like micro, pharm, things that aren't so concept and application heavy, things that are more, you know, you can actually just like cram all the material into your head. You can save that for the end. 4, focus on the high yield material and the previously learned material, rather than try to accumulate all of the esoteric knowledge. Solidify what you got, and solidify what's high yield, most importantly. 5, allow time for breaks, exercise, and personal issues. I cannot stress this enough. Life does not stop because you are studying, and life will not stop when you're a doctor and are even busier, to be perfectly honest. Make sure you're taking care of yourself. Don't burn out too quickly. This road is too long to burn out this early. And finally, stay relaxed, stay grounded. You know, part of the overall wellness thing is to not tunnel vision this exam so much that, you know, you lose track of literally everything else in your life. There is life beyond this. And as it turns out, the people I knew who all did really well on this test were ones that kept that sort of in mind.